This is my client Joyce, who flew in to see me at Hesch Institute in Aurora, Colorado, and she comes from Pennsylvania. And she had a fall onto her sit bones in 2016 and has developed coccyx pain, pelvic pain, low back pain, pelvic pain, and has seen many practitioners, many physical therapists, pelvic floor therapists, postural therapists, physiatrist, orthopedic consults, chiropractic care, and has very limited tolerance to exercise. My evaluation reveals a very rigid pelvis, not only when she walks, but also with passive motion testing. And this is a common pattern that I find in people who have fallen onto their sit bones. And the sacrum gets wedged posteriorly. It's not made to move that way, but it appears that the SI joints gap on impact and the trunk is flexed forward and the upper body weight goes right through the middle of the sacrum, glides it backwards, and makes it stuck. And this is our best model, and I will demonstrate the palpation spring testing for that pattern, and then I will demonstrate to you how that changes. I can't image another model explaining this phenomenon. And in response to that, the body becomes very rigid. L5 does not move either. It's connected to the sacrum. And the upper cervical spine becomes very rigid, which I will demonstrate. So I'm now going to show the passive motion testing. There is no lateral glide. I mean, very, very little. I take up the slack in the lumbar spine, and then I cannot get it to glide that way at all. A normal pelvis with her age and body type would have distinct lateral movement. I cannot induce posterior rotation of the pelvis. Very, very rigid. Okay, lie on your stomach, please. When I palpate the PSIS, which is very prominent, I'm on the very top of it, and then I palpate the sacrum is posterior in relationship to the PSIS along the entire length. The lower sacrum is significantly posterior, and if I walk across, slide across, my thumbs don't even touch. Now here at S2, my thumb that's on the sacrum, if I slide it across, it overrides the thumb on the PSIS. And in most people, the PSISs are posterior to the sacrum. There is no spring in the sacrum, and there's no spring in the lower sacrum. There's no spring in the upper sacrum. And at L5, there's no forward spring. But you can see that at L4, we can load it and spring it. And this is how we should perceive movement throughout the pelvis. You should be able to load it to a stop point and then add an additional thrust, and you should get a little forward spring and then a recoil. And the rest of her thoracic spine springs rather well, and the same with her ribs. I hope the camera angle can capture the ribs, but anyway, they do spring as well. There is no inferior spring through the pelvis. There is no superior spring in the pelvis. There's no forward spring through the ischium. And the sacrotuberous ligaments feel rock hard. This feels like a bone, but this is a ligament. It's extremely tight because sacrum is posterior. She also has a side bent tailbone. So my right index finger is much higher in the sulcus, in the sacrococcygeal sulcus, than on the left, and that's by at least 1/4 inch. She's had lots of efforts at mobilizing the coccyx. Incredibly, she tells me that it lasted, the manipulation lasted only 5 seconds. When I reduce a side bent coccyx, I push on the ligaments on the right side of the coccyx for 5 minutes. I then push directly on the coccyx for 5 minutes. It takes that long to move it. And a quick internal effort at mobilizing the coccyx just simply is not effective. I'm going to now have her lie on her back, and I will show you a spring test, doing a traction test to the upper cervical spine. And I'm keeping her face out of the camera to preserve her privacy. When I put my thumb in front of the mastoid process and I try to spring it to the left and to the right, there's no movement. When I come under the mastoid and I try to lift up towards me with a reasonable amount of force, there's no movement, and I can feel this incredible tension in the sternocleidomastoid muscle. And now I'm on each side of the transverse process of C1, which is also called the atlas, and I'm pushing to the right and there's no give. And now I'm pushing at C2, and now you'll see distinct motion. So the upper cervical has blocked motion at the occipito-atlantal joint, where the head joins the neck, and the top 1 and 2 vertebrae, called the atlantoaxial joint, are also very, very rigid. Nothing is moved out of place here. Its muscles are reflexively guarding in response to the sacrum. When the sacrum glides posteriorly, it shifts the center of mass posteriorly, center of gravity. And then in response to that, a reflex in the body moves the head forward in extension to counteract that weight. The only way to unlock this, I could work forever on her upper cervical spine and get nowhere, because it's reflexively driven and you have to treat the cause. So it requires a whole body approach. And when I free up mobility in her pelvis, this will probably melt on its own without any need for direct treatment. If I try to lift her head up, it's extremely tight in that first joint. If I try and do traction to the upper cervical, which requires contact on this part of the head, there's no traction mobility. Now if I flex her neck and then take the upper cervical out of the system, you can see that she has traction mobility in the mid and lower cervical down through her body. I can see movement in her abdomen. I can see her feet move up and down. So again, I'm not going to have to treat her head and neck directly. That will release in response to direct treatment to the pelvis. Also noteworthy, just relax, open your mouth slightly, let your teeth relax, is that her TMJ is really tight. I'm trying to spring it, and I just see so little movement when I spring on the mandible. And when I compress mandible superiorly, there's just no yield. And she asked me about, do I treat the jaw? And why did you ask me that?
Because I've been diagnosed with TMJ and was recently told about how much the left side pops out when I open my mouth. Up in here.
Very good. Well, we will evaluate that separately after we restore movement in the upper cervical spine. We'll look at that more closely. And so I'm going to demonstrate the treatment that I'm going to do for her rigid pelvis. Let me have you lie on your stomach again. You can pull that headpiece out. So I'm going to have her lie on her stomach for 5 minutes. And I put this 2-inch by 4-inch by 8-inch long foam under the ilium on both sides. I do that for 5 minutes. After 5 minutes, I will then keep it there, but I will then push on her sacrum at the level of S1, 2, and 3, because that's the level where the SI joint is on both sides. So I will then push on that for 5 minutes. And after that, we'll redo those passive motion tests. We will look at her upper cervical again and have her walk again and ask her how she feels. So I'll stop filming now and I'll come back after 10 minutes have elapsed.